Welcome back to session 7 of track 1. We'd like to thank all our attendees who are still here with us for another set of informative lectures and discussions. Without further ado, I would like to introduce our chairperson for this session. He is Dr. Padma Raju Vare. He is the head of Department of Psychiatry at the Medical Center Specialty Hospital in Abu Dhabi, United Arab Emirates. He is the chairperson of the Continued Medical Education for more than a decade, and is on the board of Medical Research Ethics Committee at NMC Hospital, Abu Dhabi. He's been in many public and has done a lot of motivational speaking for many corporate customers in the United Arab Emirates. Without further ado, I would like to hand over the session to Dr. Vare.
Good evening, all the attendees. First of all, let me thank the conference organizers, Dr. Muhammad Al-Garhi, Dr. Medat Al-Sabahi, for giving me this privilege and opportunity to chair this session and to speak on a particular topic later. Let me first, to start this particular session, let me first introduce the speaker. The first speaker is Dr. Gabriele Rocca. He is the president-elect of the World Association for Psychosocial Rehabilitation. He is a psychiatrist and psychotherapist from Italy. Currently, as you know, WPR, that is the World Association for Psychosocial Rehabilitation, has 48 international members on board of directors, and our renowned Dr. Medat Sabahi is one among the board of directors. Dr. Gabriele Rocca has been very active in psychosocial rehabilitation in many countries, not only in Italy. One of his publications I was going through was that in 1999, I remember, one mental hospital near Milan, that is Antonini Mental Hospital, was closed, and all the patients who were resettled in the community, and he organized a very good study to reassess them. He is going to speak on COVID-19 pandemic, mental health, and what happened in Italy. Yes, Dr. Floor is yours, Dr. Gabriele Rocca.
Good afternoon. First of all, I would like to thank the organizer of this very interesting conference, and I would like to extend my friendly greeting to Professor Medad El-Sabahi, with whom I have been collaborating for years in WAPR. My presentation is about the Italian mental health system during COVID-19 pandemic. I'm obviously referring to the first phase of the pandemic during spring 2020. Italy was the first European country to face the COVID-19 pandemic and to implement a very strict lockdown. All of a sudden came an anguished and dark astonishment, followed by the awareness of the epidemic's seriousness and the risks that everyone was taking. People have respected the rules of lockdown and were able to deal with the disease even in their own homes. We can grasp the emotional climate of those days in the words of a doctor dispatched to Bergamo, a city affected by severe COVID-19 outbreak. Their words: there is this sense that the enemy could be anywhere, and in any given moment you can see this in the eyes of the people who live here. They express, without even wanting to, a profound sense of loss. These are scars that stay inside. let's start by looking at some data. To date, more than 600,000 cases of coronavirus have been confirmed. The death toll, a terrible toll, is estimated to be up to 38,000, a number considered by many too low, as suggested by data comparison between the number of deaths in the same months of 2019 and 2020. 15,964 people are hospitalized in various units and 1,651 people are in intensive care units. Moreover, health workers caring for COVID-19 patients were exposed to a high risk of infection and death. 183 doctors and 42 nurses died since the pandemic outbreak. Before to present the consequences of the pandemic, I would like to briefly describe the Italian psychiatric care, the Italian psychiatric system, which is universal, cover all the citizens, receive public financing, and is integrated with the other structure of national health service. Is based on the departments of mental health. The departments are responsible for prevention, treatment, and rehabilitation of mental disorders in a catchment area. In Italy, there are 143 departments, which treat about 800,000 patients each year. Community mental health centers, the heart of care, is a part very important of our system after closure of all psychiatric hospitals. In Italy, there are 1,374 community mental health centers. And then, for the acute crisis, obviously, there aren't psychiatric hospitals, but units in general hospital. And we have 4,910 beds, about 1 bed per 10,000 inhabitants. The involuntary compulsory admissions are 7,407, 1.5 per 10,000 inhabitants. And there are, besides, about 29,000 beds in residential facilities. I would like to clarify that each residential facility has a maximum of 20 beds. And finally, the day center. 26,500 places in day centers. Well, psychiatric care and COVID-19 pandemic. The lockdown came suddenly, and the health system, not only psychiatric system, the health system was unprepared. What has been the impact of the pandemic on the functioning of Italian psychiatric services? few reports have yet been published on how mental health services have downsized their activity, and especially on what strategies they followed. I will present the information we have. Community mental health centers activity was reduced by ensuring urgent interventions. 14% of them, of community mental health centers, have been closed. Remote support has been implemented to replace the interrupted task, and this constitutes the innovative and evolutionary aspect of the crisis. Many day centers have been closed, while the ones remained open had to decrease their activity, and therefore patients have lost the possibility of having interpersonal relationships. About hospital and residential facilities now. Some general hospital psychiatric units have been transformed, completely transformed into COVID units or into COVID units for psychiatric patients. Furthermore, psychiatric workers have been suddenly transferred to COVID units. Within the residential facilities, the situation was more complex. Some patients were discharged from residential facilities, or family members were no longer able to visit patients within residential facilities. And I think, first of all, patients could not go out and were therefore forced to live in confined spaces. In other words, they were suddenly forced to experience confinement more typical of an acute psychiatric ward. These significant transformations have had inevitable consequences for users, staff, and the general population. It's therefore necessary to understand what has happened, what has worked, and what has not worked in an attempt to transform this dramatic crisis into an opportunity to positive evolution. To address this problem, we developed an ad hoc questionnaire to find out what the professionals thought about the new organization and how they felt at that time, what they felt. The questionnaire, not validated, was accessible on the WAPR Italy website. The questionnaire included 5 questions for social demographic characteristics, role, and setting of the professional, and 8 multiple choice questions concerning opinions about the service activity in the lockdown. Between the 28th of April and the 31st of May 2020, the questionnaire was completed by 1,046 professionals. 1,046. A convenient sample. They were, you can see, predominantly females, and 50% were aged 46, 60 years, and worked in northern Italy. 42% work in community mental health centers. about role, occupational therapists and nurses are the ones who responded most frequently. 28 and 23%, 25, respectively. And then doctors, 18%, psychologists, 11%, and other roles, but I would like to highlight also peer specialists, 2%. These proportions are in line with those reported by the Italian mental health system in relationship to physicians and psychologists, whereas nurses are underrepresented and occupational therapists overrepresented. And now, the question about the organization, about what the professional thought and felt. First, problematic aspects. I present the question and the most frequent answer. The problematic aspects of the work during the lockdown, staff reported to be worried for their families and their own health. And they were similarly worried not to be able to offer adequate support to the people with most severe conditions. More negative aspects or answers phrased in a more negative way, like for instance, to be asked to do things they cannot do, or to feel not to be useful enough, or to stand the worry for some severe patients, accounted for 16% of answers altogether. The change deemed most useful was delivering continuous online support through communication technologies. This might include two different meanings: the ability not to leave patients alone, and the introduction of communication technologies as a new professional skill. Answering to the question about the most useful change implemented, besides a wide appreciation of remote regular support, 46%, we have the choice having clear rules to follow, 18%, and to put a limit to patients and family members requests by 17% of the sample. With reference to what could be done to better cope with the lockdown, respondents identified the ability to adapt activities according to specific characteristics of each service, whereas hiring new personnel was the option less frequently selected, only 5%. In implementing the lockdown, respondents regretted the lack of attention to the specific conditions of each service or type of setting, the specificity, the specific activity that each service, each professional has in his activity. Indeed, the lockdown and the need to close services and reduce activities in very few days found everybody unprepared, and there was no time to adapt changes, closures, or continuation of activities to the characteristics of each service. And now subjective experience, I think, very important. Despite the difficult working conditions, They thought that there could be some positive outcomes. Their feeling was characterized by a general positive attitude, with 30% feeling useful and only 2% answering they were afraid not to do it. Professionals confirmed their interest in new forms of communication, and at the same time, they suggested identifying work objectives with greater accuracy. Perhaps the organization's crisis due to the pandemic has highlighted the need for a transformative process. Change in the relationship between professionals and patients. More than half of the professionals, 56%, think the relationship has changed with the patients, or at least with a part of them. The work is characterized by an aspect of novelty and uncertainty, because they change can produce uncertainty. Type of change. A not neglectable percentage of respondents, 22%, thought the patients tended to be more closed in themselves. But for 32%, the relationship was free from aspects linked to the routine. Free from aspects that represent the repetition, the day by day, always in the same way. We could say that uncertainty can allow an evolution towards autonomy, because certainty often means chronicity. Not infrequently, a professional who has had in charge a severe patient for many years may not recognize the signs of a possible evolution that come from the patient. The pandemic has forced change on both professionals and patients. And the last question, consequences of reducing activity. People living alone seem to be those who suffered the most from the reduction of activities, whereas those with psychotic symptoms seem to suffer less. So, professionals value a social aspect more than a clinical one. Conclusions. Professionals appreciated a wider and consolidated use of communication technology, and that can be seen as a need for change and optimization of activities within the psychiatric services. The epidemic is having such an impact that we cannot miss the opportunity to gain prompts for the future at short, medium, and long term. Some aspects, like a wide and regular adoption of communication technologies, can be easily realized, and mixed strategies in person and online should be implemented according to users' needs and preferences, physical characteristics of the area, and other factors. And then the discontinuity in the usual way of working may have facilitated the assumption of a new perspective and a new definition of what really matters for the person. With this different way of looking at the history and needs of patients, it will probably be easier to realize less predefined and more individually tailored rehabilitative programs. The adoption of evidence-based interventions may not be sufficient if they become a standardized answer given in a standardized, not personalized way. And the opinion of professionals. Much more than the diagnosis, user loneliness emerged as a reason of concern. Actually, several anecdotal reports in the epidemic period noticed how the conditions of the patient seemed to be stable, if not improving. This connects to the question about how much patients should be prompted to take an active way of living, and how difficult can be dosing prompts and opportunities for activation and socialization according to patients' characteristics, preferences, and clinical conditions. Anyway, patients living alone were seen as those at higher risk to suffer from the lockdown, in agreement with a paper from the UK with similar objective. We have to remember that social isolation not only contributes towards physical and mental health directly, but could also expose to a higher risk of abuse and traumas. In a population like mental health service users, with physical health poorer than in general population, reduced care may produce serious consequences. And finally, our knowledge of the impact of the pandemic on mental health services and users is still not sufficient. We need other investigation, but investigation that also involve users. Thanks for your attention.
Yeah, we are now going to the second speaker presentation. I'm going to introduce the speaker, Professor Amir Hussain from UAE. Professor Amir Hussain is currently a visiting professor of applied psychology, School of Psychology, Faculty of Life and Health Sciences, University of. We are now going to the second speaker presentation. I'm going to introduce the speaker, Professor Amir Hussain is currently a visiting professor of applied psychology, School of Psychology, Faculty of Life and Health Sciences, University of. We are now going to the second speaker presentation. I'm going to introduce the speaker.
Hi, I am Amir Hussain. I'm professor of child, adolescent, and family mental health, trained in child psychiatry at the Institute of Psychiatry, University of London, and then also Birmingham Medical School. I'm the fellow of the American Academy of Experts in Traumatic Stress, fellow of the Higher Education Academy, UK, taught in the higher institution in the UK for over 20 years, supervised various PhD students, and was director of child, adolescents, and family mental health for several years. Currently visiting professor of child, adolescent mental health, University of Ulster, United Kingdom. I'm privileged and honored to contribute a presentation to Abu Dhabi International Mental Health Conference, November 2020, on a paper entitled Building Mental Health Resiliency Among the Public and Emergency Staff in the Wake of COVID-19 Pandemic. I'm going to highlight the outline of the presentation. So the outline of the presentations will be start with some useful, relevant references, which mainly coming from the BMJ, British Medical Journals, current issue, November 7 issue, and WHO statistic, and National Institute of Mental Health, USA statistic, and John Hopkins, also stat and maths on COVID-19, especially on infection rate and mortality rate and hospitalization rate and so on. Also, I'm going to provide you with some rationales about why the presentations matter, and perhaps size and prevalence of mental health problems in lifetime, and then size of mental health problem in a crisis and disaster situation. And also current debate about prevalence. The WHO, the ICD, and perhaps DSM, prevalence and size of mental health problems. So the American versus the European size of mental health problem. And also I'll be looking during the presentations about the prolonged stress and who are vulnerable and at-risk group, identifying people at risk, and contributing factor. I'll be highlighting also and discussing contributing factors to mental health problem in a crisis situation. Current COVID-19, it's prolonged crisis now, and it's damaged economy and contribute to mortality rate, hospitalizations, and perhaps other uncertainty, which we'll be talking about. And also I'll be talking about the relationship between stress and the immune system in a prolonged stress or the stress situation. So also put some emphasis on the reactions of the public, especially children and families and emergency staff in a crisis situation. And then final slide of this presentations will focus on management and coping with stress among the public, families, and perhaps staff in the front line, emergency staff. Let's look now at the maths and the statistic. Global infection rates, it's exceeded the 50 million. Global death exceeded the million death as a result of COVID-19 pandemic. Looking at USA infection rate and UK infection rates and make some comparison between both. USA infection rates is now exceeded to 9 million. So almost touching, in a few perhaps weeks time, it will be touching 10 millions infection rates. And death rates, mortality rates, it's almost reaching 250,000, 200,000, 33 and 292 mortality rate. UK infections is now exceeded 1 million, and total mortality rate or deaths as a result of COVID-19 pandemic. It's almost reaching 50,000, almost reaching in perhaps 2-3 weeks time. Look at some also maths and statistic, European statistic, and also South American statistics. If we look at, for example, France, Spain, Italy, and also infections, it's exceeded 1 million. Apart from Italy, it's 900,000, 35, and 104 infections. And of course, comparison with Brazil, 5 times infections than France and Spain and Italy. It's reaching 5 million infections in Brazil, and death, it's 100, in Brazil, 162,035. And death, for example, in UK, France, Spain, Italy, it's range between 38 and 41,000 death and mortality. It's quite high. Rationale of this presentation is due to, of course, explosion of infection in every age group, and significant of hospitalizations and concerns about the welfare and the morals of people working in the front line. And also the significant death, and also the second wave and winter season, especially in Europe. And as I said, the explosion of infections in every age group, it's materialized now as we are approaching the winter time. And also among the public, COVID-19 fatigue syndrome and manifestations of reaction of PTSD resulted from death, griefs, and anxiety as a result of uncertainty, depressions as a result of losses, and mood disorder also among many resulted from PTSD. Let's look at the mental health prevalence in lifetime situation. And these are the figures of United States figures and DSM figures, and also WHO, ICD figures. It's been suggested that mental health problem, it's between 17% and 29% if you take in any random situation. Depression, it doesn't exceed 10% of the population, whereas anxiety is usually high, almost 1 in 5, that is 25%, reaching sometime to, according to the various study which been perhaps circulated and published journals, around 20% anxiety in any time you can find. PTSD reactions is usually in any time situations might manifest to 8%, usually in any random situations. Usually females, it's been suggested that react to situation and uncertainty and crisis situations and disaster situations is higher than male subjects. Being suggested it's 1 to 2. So it's higher among female than male counterparts. These are the prevalence which been found, and you find it in the ICD and DSM, and you find it also in various published articles, journal articles, and these are the lifetime prevalence. And this is also PTSD. As I said, it sometimes reach 8% in lifetime, and as it's been suggested here, men's, it's usually their reactions lower than females. And usually I challenge that particular prevalence. Usually men subjects more likely to perhaps have accidents and more likely to smoke, more likely to drinks, and therefore perhaps manage and cope differently from female situation, usually articulate their symptoms and anxiety and tensions and distress situations usually to their friends, to their perhaps elders, and so on and so forth. That's why you find it's usually higher. And so the reactions of individual is totally different from, and variables from situation to situations and from genders and through different groups. A school of thought, the prevalence and reactions of PTSD or post-trauma. I'm talking about post-trauma and post-crisis situations. And this is, we are currently in crisis situations, and mental health manifested as a result of uncertainty, as a result of the crisis situations. And the present school of thought prevalence perhaps conservative, and then the American school of thoughts, whereas the prevalence in the American published articles and papers more likely to be higher than those of published in British journals. So what I'm trying to say, and these prevalence, you might perhaps challenge this prevalence, and you might say at some stage higher mental health situations, higher during crisis situations, and others find it's lower. And this usually resulted from perhaps the size of the populations and methods of the study being conducted, and several other factors which contribute to the higher or lower prevalence. Prolonged stress. We are currently under prolonged stress, and the pandemics started when the WHO revealed that we are facing pandemics. It was on the 30th of March last year. Sorry, this current year, 2020, March, 30th of March, 2020. So since then, we are exposed to great deals of challenge and uncertainty and situations of never been before, and business being perhaps damaged, and schools being suspended, and travel being suspended, and perhaps still we are facing the second wave, and especially in Europe. It's more likely now, hospital is now beds overwhelmed, hospitals overwhelmed with infection rate, high infection rates, and so on. As a result of all these things, as a result of infections, as a result of mortality, as a result of stress, prolonged stress, as a result of hospitalization, and again, uncertainty, a lot of anxiety will be manifested, a lot of depression will be manifested, a lot of PTSD reactions will be manifested among children, among the publics, among the adolescents, among the young, among the even professionals. Crisis situation is likely to increase anxiety, increase depression, increase PTSD reactions among all population, children, adults, and professionals. I remember recently a professional's paramedics approached me. He said to me, I'm thinking of dying. And I said, why you are thinking? And he was on resting time, and he has 2 days resting time. It was in his last day of resting time. He approached me and he told me, I'm going to die. I said, as a result of what? He said, I'm frontline. I could be dying, get infected, and could be dying in any time. And I said, is that reality, or is that only thinking and negative thinking? He said, no. My wife delivered the baby and I am not able to see that baby, and I'm not going to touch I'm not able to touch, I'm not going to cuddle that particular baby, and I am thinking I might die and without seeing him, without touching him, without cuddling him, and he might never see me. So this kind of negative thinking and perhaps can contribute a great deals of influencing in negative fashions the performance of this particular individual. So what I'm trying to say, I said anxiety and tensions and reaction, PTSD reactions, and manifested and among children, among the public, among the young, among the adolescents, among the professions, among families members. So who are at most risk groups? If we look at this slide, we will find, and the first and foremost, front life emergency staff, professional staffs, whether doctor, nurses, paramedics, ambulance people, and all these are really at risk group. And also other at risk group, individual who have psychiatric history, those individual with compromised immune system and chronic illness, and the elderly also at risk group. Those other people who are at risk, the newly diagnosed individual, the isolated people, those who are isolated, those who are perhaps lost their jobs and become unemployed, family members, children and adolescent, and other member of the public. Perhaps I haven't mentioned some of them in here, can suffer also a great deals. And also, as I said, individual with OCD, obsessive compulsive disorders of, as I said, individual with mental health history. Home environment. What do I mean by home environment? I mean, mothers and fathers who express anxiety and tension, more likely to transfer such an anxiety to their children and young member of staff in the family. As I mentioned earlier, newly diagnosed and hospitalized, and these do manifest some PTSD reactions and anxiety as a result of the pandemic. Professionals more likely also to manifest a great deal of anxiety and tension as a result of proximity, as a result of high casualty, as a result of mortality rate, as a result of media influence, as a result of news, as a result of high infection rates, as a result of hospitalizations, and as a result of lack of support from their own organizations and institutions. So age, also genders and professions can contribute. We mentioned at risk group. So genders, female, it's been suggested in the literature, is more likely to manifest their tension and anxiety and perhaps explore it with relevant friends and acquaintances. Professionals who are in the middle and who are in the front line, in the middle of high casualty and high mortality rates. Proximity is matter. of course, exposure to media can also influence tension and anxiety. Prolonged stress has been suggested the enemy of the immune system. So, reflecting on the relationship between prolonged stress and the immune system, it's been suggested prolonged stress is the enemy of the immune system. The immune system is usually reduced functions and number of white cell as a result of being exposed to prolonged stress situations, and also damage the immune system, suppress the immune system. It's not only damage the immune system, but suppress the immune system. And also making the immune system release hormones and damage tissues and cells, making individual vulnerable to disease and increase symptoms such as pain, headache, high cholesterol level, and increase, as a result of anxiety, increase insomnia, and perhaps increase inflammations, allergy, hypertensions. And so prolonged distress situations is really making the situations worse for vulnerable individual and at-risk group. If we look at the reactions of the public and children during a crisis situation, everything should be regarded as a normal reaction to abnormal situations. So the mood problem and the tensions and the anxiety and perhaps the nightmare, the concentration problem and the guilt feeling, the psychosomatic illnesses, the headaches, the numbness, the lack of social interactions and withdrawals, sleep problems and hypersensitivity, and most these reactions are normal unless they are lasting a month and beyond. And of course, those who have obsessive compulsive disorder and psychiatric history and newly diagnosed and hospitalized, these are different group. But otherwise, these reactions, whether it's mood, whether it's tension, whether anxiety, whether it's withdrawals, whether the guilt feeling, whether the psychosomatic numbness and lack of social interaction, and these are normal situations and reactions to abnormal situation and the crisis situation, unless it's lasted. So we expected to see among the public reactions, which could be attention, could be perhaps withdrawn, could be lack of concentrations, and could be anxiety, could be nightmare, and could be insomnia, and could be again hypertensions, and could be lack of concentration problem and lack of interactions. And it is normal unless it's last beyond 1 month and 3 months and so on. So if we look at the expression of tensions and anxiety among children in a crisis situation, children cannot articulate perhaps their anxiety. So most of their anxiety are manifested through perhaps mood problem, through their play, through their writing and drawing, and through attachment and being close to perhaps the mothers and the fathers. So, and through they are staying so close to parents, or sometimes poor mood, aggressive. The recommendations to parents should stay calm, stay close, be visible, and be positive and hopeful. So to summarize, reactions of children in crisis situations, it can manifest through various ways. Play, staying close to parents, and perhaps even sleeping with parents, and a mood of sleep would change during a crisis situation, and they need to be very close to parents and sleep with their parents and sometime, and need to see their parents are close and visible. Parents should be positive, hopeful, and stay calm and stay close, and attachment is matter, children, during a crisis situation. So they manifested their anxiety through attachment, being close to parents, and through manifesting perhaps poor mood, poor concentrations, inability to sleep also sometime as a result. So once again, the recommendation to parents should be staying calm and positive and hopeful, and should be always visible and understand the mood change, the mood swing among these children, whether they are children beyond 10 or adolescent. Reactions of emergency staff in a crisis situation. As I said, most of these reactions of staff and children and parents are normal unless these reactions are lasting. Reaction of emergency staff determined by number of casualties, mortality rate, and perhaps constant exposure to that particular casualties and mortality rate and infection rate and hospitalization rate. And of course, as they are close to their patients and time and again, and exposure to death and dying and to deceased individual, these matter in a crisis situations. So reactions of emergency staff, whether it's guilt feeling, whether it's sick leave, or whether it's mood swing and mood change and perhaps depressions and anxiety, and could manifest during a crisis situation. And perhaps managers should understand these kind of reactions, whether it's sick leaves, guilt feelings, and other reactions, and especially lack of social interactions and anxiety, and perhaps lack of concentrations, and smoking, and can be another way of coping. What is happening during a prolonged distress situation? I think this perhaps slide can perhaps partially explains what's happening, why its fatigue is taking place, why its exhaustion taking place, why its withdrawal is taking place. As everyday exposure, as every day's mortality rate is mounting and infection rate is high, hospitalization is high, and as this is continue, individuals who work with a close proximity with patients and with hospitalized individual more likely to try to resist and cope with the situation as much as possible. And as you can see now, this is the resistance, this is the alarm, this is the problem. It's the alarm as started to ignite stress and anxiety among individual. So anxiety, it's here, it's high perhaps, and resistance is perhaps would be the second stage, the alarm stage, and the hospitalization, the death, and the infections and mortality rates. It's high. So all this ring a bell, and individual get alarm as a result of this, and the resistance will continue. Individual try to meet that particular challenge as much as possible, and of course exhaustions will take place as a result of this, whether it's among the family members or among the parents or amongst the individuals who are as a frontliners and individuals who deal with infections and with mortality and with diseased individual, with hospitalized individual as a result. And that is why organizations and staff and managers should understand the situations. If individual it's kept asking for perhaps resting time or perhaps sick leaves and manifested and changing, and sometimes even absenteeism as result. But these are really a small percentage of individuals who can manifest a great deals of this. Otherwise, the situations it's need to be addressed in a professional fashions. As a result of that particular exhaustion, reaching to that particular stage, burnout, we're talking about professional fatigue and professional burnout. What's happening when exhaustion take place, illness take place as a result, because the immune system will be perhaps done and becoming, it's less likely to be able to resist prolonged crisis situations. And despite the resistance, you find individual more likely to bend as a result and manifest illness and manifest weakness, manifested perhaps cognitive problems and emotional problem and social problem, and reductions in mood, in cognitions, in emotions, and social, and withdrawn basically as a result. So you need to watch about these perhaps 4 elements of this slide: the emotions, mood swing, and perhaps aggressions, and perhaps anxiety and worries and sadness and grieves as a result of mortality rate and depressions. Cognitive element of reactions of PTSD to crisis situations is memory problem, concentration problems, perhaps psychosomatic illnesses, headaches, and pain, and high blood pressures, and intestine problems, and behavioral problems is sleep perhaps problems, and withdrawn, and aggressions and abuse, and smoking and drinking to cope with the situation can take place also as a result of crisis situation. Coping and stress management for emergency leaders in crisis situations. So leaders and managers need to monitor stress, monitor safety procedure, respect professionalism, honor staff, be calm, be positive, be hopeful. And also, manager should look at workload and increase resting time and increase teamwork relations and provide clarity and good informations to staff and meet the need of individual, the social need, the emotional needs, and the psychological needs, and also need to encourage exercise and provide support to individual, and perhaps encourage regular sleep, encourage healthy eating, and monitor, as I said, stress situations and reflect on safety procedures and respect professionals and dignify and honor staff as much as possible for their hard work. And try to perhaps encourage individual not to smoke and encourage individual to seek social support and stay connected with loved one and avoid negative thinking. So a lot of negative thinking can produce an anxiety and tension among individual staff working in first line and in front line. And individual need to ensure taking rest, sleep well, eat well, engage in exercise, and protect their health through regular sleep, and also limit exposure to news and negative thinking. As I said earlier, children and anxiety often expressed through play and activity and drawings and mood swings sometimes, aggression, and through close attachment, and try to avoid sleeping alone. A lot of children during crisis situation, especially if there is high anxiety and tensions among the family, therefore children manifest their anxiety through being close to mom and dad, and through attachment, avoid to sleep alone. And through, of course, play and activities and aggressions. For parents, as we mentioned earlier, need to be staying calm and visible and stay connected with children. Reassure these children about the uncertainty. So these are some messages for the individual in the front line, for the managers, or for the parents also. For the individual in the front lines, they need to eat well, sleep well, and stay connected. And of course, managers and leaders need to recognize, need to honor the hard work staff are doing, and build self-esteem. And also leaders should recognize survival needs. So anxiety and tension is a need for survival. So these people, if they manifested anxiety and they manifest tension or aggressions or withdrawal or sadness, these are survival needs. So individuals in crisis situations, yes, they need rest, they need a safe place, and they need to be connected, and they need to be respected, they need to be honored, they need to be recognized, and leaders should recognize survival needs also. Any individual during threatening situations, and pandemic is a threatening situation for everyone, for the paramedics in the front lines, for the emergency services staff, for the parents, and for the children, and for the perhaps other individuals who work in emergency settings is a threat situation. And a threatening situation, often the case manifested a great deals of reactions, but these reactions are normals to abnormal reactions, to abnormal situation. Hence, managers, parents, and perhaps staff working in organizations delivering services, emergency service should recognize that individual needs for perhaps safety measures. They need perhaps good night sleepings, good eatings, good exercise, and perhaps need to be workloads need to be also recognized and done in a pretty fashion. These reactions are normal, as I said, resulted from abnormal situation and a crisis situation and threatening situations, threatening to the well-being of individual. This is perhaps the tip of the iceberg, and I think we need to wait up until the dust will be settled, and as a result of losses, a great deal of losses during this pandemic period, prolonged period of crisis and pandemic, and a great deals of anxiety and depressions, and perhaps a lot of mood problems and emotional problems, a lot of griefs will be manifested as a result during perhaps aftermath, when the dust will be settled and when the situations will be come to normality. Thank you very much indeed for having been with me during this
Maybe you are wondering what is this COVID insomnia? This is a new term. Is it a neologism? Some of my psychiatric friends have asked this, but I'm working in general hospital setup as a psychiatrist. We have many other specialties, the rheumatologists, orthopedicians, etc. And they use the term as a pain insomnia, which refers to sleep issues because of the pain. So it is like due to fears of about the coronavirus, concerns about being isolation, able to go to work, not having social contact with other people, they are suffering from disturbances in their sleep patterns. During the present pandemic, sleep neurologists and psychiatrists are seeing a surge in number of patients with the sleep disturbances associated with COVID-19. They are nowadays terming this as COVID insomnia. So the objective of this presentation is I will run through refreshing your memories about the basic sleep cycle. Let us see the epidemiology of insomnia in general. Besides these objectives, more interestingly, going deeper, we will learn how COVID-19 impacts sleep in various demographic groups. Are men and women more likely to struggle with sleep, with the difficult times? Do people in places where COVID-19 is active and during the lockdown period tend to sleep less overall? Are baby boomers losing more sleep than millennials? Why do we need sleep? Sleep is an essential function. Sleep is a restorative. Sleep is an integral portion of human existence. The most physiological and pathological changes like aging and all affect it. Why do we sleep? Sleep is mandatory for the development of human brain development. Sleep is an essential function that allows your body to recharge, leaving you refreshed and alert when you want to. Without enough sleep, the brain cannot function properly. And sleep helps with information processing and involved in pruning and tuning. Sleep is restorative. How do we get sleep? Answer is circadian factors play a major role. The brain is active during sleep. Even during sleep, the brain neurons are very active. Sleep follows a regular cycle each night. Rapid eye movement, that is REM, alternates with the non-REM sleep, NREM sleep. Each cycle lasts 60 to 120 minutes, and there are 4 to 5 cycles in a night. The NREM and REM repeats throughout the night, and REM records are increasing, and the length of the delta sleep goes low and low until during the last few cycles there is no delta sleep, and NREM sleep makes up to total 80% of the sleep, and REM sleep makes only up to 20% of sleep. Dreams occur usually in the REM sleep, rapid eye movement sleep. Let us see the circadian rhythm, which influences the sleep cycle. The entrainment of the circadian rhythm by light cues. The circadian rhythm runs on an approximately 24 hours a day. It controls the sleep-wake cycle. It also influences other physical and cognitive processes, including temperature, alertness, and hormone levels, etc. The rhythm is generalized internally or generated internally, but it is reset by the external cues called the Gezebergs. The strongest Gezeberg is light, which influences the suprachiasmatic nucleus in hypothalamus, and it is a biological clock of our body. Sleep is species and gene specific. All animals require sleep, not only the humans, but how much they need varies depending on the species. Different animals sleep for different amounts of time. For example, horse sleeps for 4 hours. Homo sapiens sleeps for 8 hours, that is humans. Rabbit for 12 hours, tiger 16 hours, and brown bat sleeps for 20 hours a day. Some people tend to be more alert night, while others tend to be more in the daytime. Let us go through some of the insomnia questionnaires. These are some of the frequently used insomnia questionnaires in the surveys and assessment of treatment outcomes. The first 3 are most important. There is a Epworth Sleepiness Scale, ISI scale, and the Pittsburgh scale. These are the 3 important ones. Before going that, let us see the, sorry, 1 minute. Yeah, let us understand the pathogenesis of insomnia. The behavioral perspective of persistent insomnia is given by, very importantly, by Spielman's of 3P factors, that is, predisposing factors, precipitating factors, and perpetuating factors. According to this model, predisposing factors may cause occasional night of poor sleep, but in general, the persistent until a precipitating event like death of a loved one or the present scenario of the COVID-19 impacts that, and the present context, the pandemic that triggers the acute insomnia. If bad sleep habits develop or other perpetuating factors are there, insomnia becomes chronic and will persist even with removal of the precipitating factor. Before going to the epidemiology, let us see the criteria of the insomnia. Criteria of insomnia include complaint of dissatisfaction over the sleep, about the quantity and quality associated with one of these things, difficulty in initiating sleep, difficulty in maintaining sleep, and again difficulty to going back to sleep, to return sleep if he wakes up. The sleep difficulty occurs despite adequate opportunity. So these are the criteria it has to be fulfilled, and the latest duration criteria for DSM-5 and ICSD, that is International Classification of Sleep Disorder 3, version 2014, says that it's a time limit. Earlier, the time limit, for example, ICD-10, it was only 1 month duration. Or ICSD-2 version, it was 1 month duration. But now with DSM-5 and ICSD-3, the time duration has been set for the person has to be not being able to fall asleep within 30 minutes after going to bed, and it has to be there at least for 3 times a week and more than 3 months. So this is very important diagnostic criteria limitation in the DSM-5 and the ICSD-3. So based on this particular terminology or the limitations and the restrictions, the epidemiological numbers also vary. But overall, in general, pre-pandemic, let us see in general what is the existing, what was insomnia epidemiology or the prevalence numbers. The prevalence estimates vary because of the inconsistent definitions of the diagnostic criteria. 10 to 15% of the adult population suffers from chronic insomnia, and an additional 25 to 35% have transient or occasional insomnia. The most conservative estimate is approximately 6% in general population. This is because, of course, as they use different criteria, the definitions DSM-3, 4, 5, and etc. The elderly in particular are affected by insomnia, and the women are likely to have sleep disturbances, more sleep disturbances than men. Several studies have demonstrated an increased risk of mental health disorders among individuals with prior insomnia. And persistent insomnia by itself can cause depression, anxiety, or other psychiatric problems. Thus, the risk relationship between insomnia and psychiatric disorders appear bidirectional. 40 to 60% of insomnia sufferers meet criteria for at least one disorder, that is, quarter of them receiving a diagnosis of depression, another quarter anxiety disorder, 10 to 11% alcohol and drug abuse disorder are the issues. Let us see. There has been a spike in prescriptions for sleep during the pandemic. While COVID-19 makes its mark on the world economy, the reports from Express Scripts from the US, which is like IMS here, reveals that it also increased there has been a significant increase of prescriptions over a period of time. During the period between February to March 2020, there has been a significant increase by 21% of prescriptions, peaking by March 15th when COVID-19 became, or they declared the pandemic. In addition, some of these medicines have been shortages. Some of these medicines used for antidepressants, anxiety, and the insomnia, they have been added to the medicines FDA list of shortages. This analysis shows that many are turning to medications for relief, which demonstrates the serious impact of COVID-19 on sleep and mental health. Broadly, COVID-19 has disrupted our sleep in 5 ways. 1. While sleep during pandemic has typically not been very good quality, but people are generally sleeping for longer period. French people have seen biggest average increase over 20 minutes extra night each, while Germans have seen the least at around 8 minutes. A third of Britons, number 2, we are not setting an alarm. A third of Britons are no longer setting an alarm, and because of the morning routine, getting family, not sending the children to school, and commutes has been eliminated. New York residents are using 25% more electricity, presumably due to lengthy late night TV binge watching sessions. And we are struggling to sleep overall. The 3 overlapping patterns of mental health symptoms are: a cross-sectional study was conducted in China, Wenzhou province, and they collected nearly the data. A total of 972 frontline staff in Wenzhou participated in this study. 50% of the subjects were assigned to the high-risk group who were exposed to patients with COVID who were attending, and 50% were assigned to low-risk group who are attending the non-COVID patients. GAD-7, PHQ, ISI, these were the instruments administered, and the most commonly occurring form of mental health was the comorbidities of anxiety, depression, and insomnia. In another study, the Sleep Charity and Sleep Station in UK surveyed more than nearly 2,700 people to find out the nation's sleep status during COVID, and their findings reveal Alarmingly, over 3/4 say lack of sleep in their inability to function normally in the day. Close to half of the responders are finding it harder. More than 1 in 10 are experiencing significant symptoms of depression and anxiety. Women are suffering more than men with anxiety around coronavirus and are twice as likely to report feelings stressed compared to men. Women also report having more vivid dreams. In Italy, during the lockdown, that is March to May, there was a significant increase of psychological distress and worsening of the sleep disturbance. In the study conducted by Sara Marelli and others in Milan, she included 400 subjects, nearly 300 students, and 100 university students. In particular, during the lockdown, impact of Delta wave and wake-up time is disturbed, and there is a more pronounced, the sleep disturbance was more pronounced in the students than the staff members. Moreover, they observed a worsening of sleep quality and of insomnia symptoms more in the students. About 1/3 of the sample showed depressive or anxiety symptoms. The impact of lockdown was greater in students than in workers and in females than in males. There is another study from Harvard, US. The global report from Harvard draws data from nearly 70,000, nearly 69, that is 70,000 sleep cyclers are the subjects on, and this is the biggest study on date. And the key findings that include teens and young adults had the worst sleep quality, with the highest rate of feelings of depression, citing loneliness. The reason could be more technology consumption as they transition to remote work and learning. Findings indicate that people are consuming too much technology and too much news. Globally, top worries included in this study 33% worried about contracting the virus, and 30% were concerned over finances and job security. 28% worried about being lonely. This is very interesting study. You see, there has been an interesting study by the Sleep Health from US. In a survey of nearly 1,000 people, 600 said the virus was not there in their county, and 400 told they were not aware. They told no, or we are not aware. So 600 positive, that area like a red zone, we used to call red zone, and the green zone. In US, the generations are usually referred by alphabets, baby boomers, X, Y, Z. Baby boomers are those people who are born after the Second World War, 1946 afterwards. So this is a criteria, like it denotes the generations. Among these, 14% said that the fear of contracting coronavirus caused them to lose sleep overall in general. But when they categorized the generations, baby boomers were actually least likely to lose sleep, though they were more elevated risk, they have more elevated because of the age group. Conversely, millennials were the most likely to be missing sleep because of fear they would catch COVID-19. The reason could be millennials are the most connected to smartphones, social media, which constantly supply new and distressing information. In addition to social distancing, we can also take other personalized measures within our own homes, including our homes, such as cleaning frequent touched surfaces. Among the respondents, many applied this approach to bed linen or bed sheets, changing the bed sheets. Nearly a quarter responded changing their bed linens more often, 25%, more often than usual. Interestingly, a number of respondents practiced distancing at home even with spouse, reducing their degree of intimacy or sleep, and they started sleeping in separate beds, in red zones mostly. Some even restricted their children from sleeping in their beds. Young, very, very small kids, like 1 year old, less than 1 year, or like that. Those living in affected counties were more likely to take these precautions, suggesting the particular power of local threat. Let us see how the dreaming affects the pandemic era dream, the COVID affects even the dream or the content of the dream. At Harvard, dreams of COVID-19 pandemic were from nearly collected from 3,000 dreamers via online survey, and they were compared with the normative dreams from an earlier period. Total about 9 emotional scales were administered and they were analyzed. Women's dream have been more negatively affected than men dream. Overall, women showed significantly higher levels of negative emotions and references to death in their pandemic dreams. Another study, in a study of 800 Italian participants, 20% of them they dreamt explicit reference to COVID. Overall, women reported again negative emotionality in their dreams. Another study on dreams from Canada showed that pandemic era dreams resemble the dreams of people with anxiety, with animal heads, and the change of locations and the death of some relatives or friends. More REM sleep, more dreams, especially during lockdowns. Chinese reported, as you've seen, sleep cycles passes through the deep and the light in a period cycles of 90 minutes. Pressure bounds and escalates for REM sleep gradually towards the morning. Increased dreaming during late morning REM sleep, convergence of several factors. Stay-at-home orders, which stopped long commutes and working from home, improved sleep for many people, but sleep patterns changed abruptly during lockdowns. Studies from China, Finland, and the US reported increased sleep time, especially during lockdown. After the pandemic began, many people are sleeping longer, and without commuting, many people are free to linger in beds, remembering their dreams. Some early birds turned into night owls who have more dreams and nightmares. After seeing the studies, let us discuss briefly about the management of insomnia. This is pharmacological, non-pharmacological or non-drug treatments. Let me first discuss in brief about the non-drug treatments. Sleep hygiene education is meant for poor sleep in general, like exercises, preferably earlier during the day and no more than 4 hours before sleep. Avoid stimulating activities before sleep or in bed. Try avoid napping or naps. Keep bedroom dark and quiet. Curtail time in bed to only for sleep. No alcohol, no caffeine, no smoking at least 4 hours before sleep. Other technique is the stimulus control. This is mainly used for delayed sleep onset delay. For this, use bedroom for sleep only. Don't stay on your mobile phone, pads, TVs, or the TV in the bedroom. No bright lights when you wake up in the night. Don't expose yourself to, bright light when you get up from the sleep. Go to bed only when tired and sleepy. Maintain regular sleep-wake times. And there are behavior therapy techniques and the cognitive behavior therapy, especially for insomnia. This is evidence-based. It's a very much accepted as a tool to treat chronic insomnia or persistent insomnia. Nowadays, especially during the present pandemic, we all doctors and everybody, including the therapists, are doing the teleconsult, telepsychiatry, telemedicine, remote. Like now we are doing the we can say as a teleconference, virtual conference. So the same thing applies even to the behavior therapy, cognitive behavior therapy, online and all. And there is I came across a very good, very much free app. This is very useful. I have gone and I have given to many patients. They are very happy. This is called the cognitive behavior therapy that is for insomnia treatment. Is a coach. This was developed by the Veteran Administration in US. This was actually meant for PTSD and the insomnia. A very useful tool. Soon after finishing this, you can download it free on either Android or iPhone anywhere. Please, it's very useful, I want to say, and it is free, open for all. And this behavior therapy, cognitive behavior therapy, or the CBTI, it takes at least to see the response, it takes minimum 4 to 8 weeks at weekly sessions. Okay. Leave that particular. Now, let us see the drugs, how the FDA, I will deal only with the FDA approved medication for the insomnia. Basically, benzodiazepines and non-benzodiazepines or benzodiazepine receptor agonists. And there is something new nowadays, that is a melatonin receptor agonist. In general, benzos have been there since more than 45 years and are potent anxiolytics than hypnotics. They improve sleep time, but not usually the sleep latency. They disrupt normal sleep cycle and tend to cause hangover effect. The next day morning, you feel cranky enough. They make you drowsy the following day and occasional, disruption of the cognition and all. They have high potential for abuse, and patients develop tolerance with prolonged use. Drugs in this class were approved by FDA, the estrogen, temazepam, and clonazepam. Melatonin is typically not a good sleeping pill, but it is usually prescribed or recommended for anchoring the circadian rhythm problem like jet lag. And they recommend 2 hours before the desired bedtime, and it is mostly helpful for jet lag. The Rameltian is a derivative, we can say, like from the melatonin. It acts on the M1 and M2 melatonin receptors, and it is 8 milligram tablet, and it's the only unscheduled. All other drugs are scheduled flow drugs, are the controlled medications for sleep. This is a one medication. It's not a scheduled drug. It is a free medication, but I don't think it is available here. But some of the countries, the generic also is available. In general, the benzodiazepine receptor agonists, in contrast to the benzodiazepines, are less addictive. Next day sedation and hangover also would be less. Tolerance and abuse have not been shown to a major extent, but some cases have been there reported. Fewer problems with dependency, though still not a big issue. Predominantly help with sleep maintenance, the maintenance of good quality of sleep. Drugs in this class include zolpidem, zopiclone, esopiclone, etc. Esopiclone is a dose dependent and has been approved for short-term use, but it gives the dose is 1 milligram, but usually for adults up to 3 milligrams, usually at 2 to 3 milligrams only, it becomes effective. With zopiclone, the common side effect is metallic taste. Almost all the patients who take zopiclone, they complain, doctor, I'm having some metallic taste in and it is a little bit daytime sleepiness. Other pharmacological agents like old agents, antihistamines, antidepressants, and sometimes antipsychotics, some old generation and all, they used to give, but these have not been approved as remedial measures for sleep problems. Antidepressants like trazodone, doxepin, even mirtazapine, but each one has its own side effects at lower doses. Majority of the psychiatrists or non-psychiatrists, they use this as for the insomnia, but they have not been approved. So, in conclusion, summary of treatment strategies, take-home message. For transient insomnia, if it is less than 1 month, usually what happens, any insomnia patient comes for complaints of insomnia, writing a prescription like zolpidem or benzodiazepine may be the quickest way for any medical professional to respond. But sleep promoting medicines, however, are generally habit forming, and it should be reserved only for transient cases of insomnia and should be prescribed not more than 2, 3, or maximum 4 weeks. Their use should generally be limited to no more than 4 weeks, and it is inappropriate for patients whose condition has become chronic or persistent. Instead, the other measures what we have mentioned, like as you had seen, the lack of circadian cues from sunlight during the morning time and exposure to the blue light from electronics like your mobile and the TV pads and all disrupts the circadian clock, causing sleep delay. The best thing is to maintain normal daily routines, maximize activities that promote alertness during daytime. They should avoid watching anxiety provoking news and all before going to the bed. And for persistent insomnia, patients receiving non-pharmacological and behavioral therapies enjoy long-lasting better outcome, and it is the most effective, and it is almost more effective, I can say, behavioral treatment like CBTI as a evidence-based evidence shows that it's more effective for persistent insomnia. So with this, I conclude.